Hello and welcome to the HHQI webinar. In this particular webinar, we're going to cover the Home Health Cardiovascular Data Registry Overview, or what we call the HHCDR Overview. In this particular webinar, we're not going to discuss the interpretation of any of your HHQI data reports, whether that be your ACH, your oral med, your flu and pneumococcal immunization reports, your cardiovascular risk report, or even the report that the data in the HHCDR creates, which is called the HHCDR Registry Report. All of that information on the interpretation can be found in other webinars located in the same site where you found this. So we'll go ahead and get started on this particular webinar. And to do that, to access your registry, go ahead and go to the HHQI website, which is located at www.homehealthquality.org. Once you're here, click the word data on the blue toolbar going across the top, and that will take you into the data portal. You'll notice that this is familiar if you have been downloading your HHQI data reports, because you will use the exact same access to access the registry as you do your other data reports. So either log in, or if you have yet to access your HHQI data reports that are created from your OASIS information that's already transmitted and it's available, and the reports are actually in this system waiting on you, you can just click register and go through that process. Now, for additional information on how to register for the secured site of accessing your data and accessing your registry, you can find a webinar on that information under this step-by-step manuals and webinar link under the data report resources, which is the same place where this webinar is located as well. So once you have logged in, oh, one more thing, the login for data is unique from the login that you use to access the BPIPs and tools. So the general campaign access, where you access best practice intervention packages and all the tools and resources, that's one user account. The user account that you will use to get into your data is a secured user account, and it is completely different. So log into your data access site, and once you do, you'll be taken to this page. And you normally would just go ahead and use the drop-down menu and click the Get Report button for whichever report it is that you're wanting to access. But the purpose of this webinar is to talk about the registry and how to access it and input your data. So for the purposes of our discussion now, go ahead and you would click on the HHCDR tab located on the brown toolbar going across the top, and that will take you into the registry. The first screen you will see in the registry is this, and each month you will have, or each time you access it, you'll have an opportunity to select which year, which month the patient was discharged in that you wish to abstract, and then the abstract button. Now, keeping in mind, we're talking about the month that the patient was discharged, not the month that you're currently in and abstracting. So for the purposes of our discussion today, the registry is going to open on November 15th. The November 15th, when you open your registry, that will contain patients who were discharged 6 weeks earlier in September. All right, so you're going to be abstracting patients who were discharged from your agency at least 6 weeks or longer before. So you click the abstract button, and the reason for that is that it allows you to have the time to finalize your charts and get everything transmitted to CMS. As you will see, your OASIS information that you have submitted to CMS will pre-populate this registry, so it's important that we have accurate information, and that's the reason for the delay. So once you click the abstract button on this page, you'll be taken to this particular screen, which you will see once a month. Each agency, each month, will have the opportunity to select which of the measures or which of the selections you wish to abstract and focus your efforts on that month, whether it be aspirin as appropriate, blood pressure control, cholesterol management, or tobacco use cessation. You can select any one or all of these measures. It's completely up to you. But the thing is, this is a once-a-month option. Once you have selected this option and checked whichever box or all the boxes that you wish to abstract, you will not have this option again until the following month. So let's say this month you're going into it a little apprehensive, trying to say, I just want to do one measure. I don't want to get into it too deep. That's perfectly fine. If you're trying to select the most important measures, we would suggest you look at either blood pressure or tobacco, because those are the two areas where most body systems will be impacted. So choose blood pressure or tobacco, or you can choose any that you wish, absolutely. Once you do, click the Save Settings, and you will move on into the registry. This will be what your similar to what your registry will appear as. You'll see in the top what measures were selected for this particular month, and then you will see the titles of each of the columns. In this particular case, you can see it's listed as CCN, patient ID, start of care date, discharge date, and last save date. Now, the patient information on this particular screen is covered with the blue box below the red outline. Yours will not have the blue box. You will have the patient information, and you will notice it. Now, the only reason I mention these the column titles is that if your EHR shows your patients or displays your patients based on discharge date, it would be nice if the registry mirrored that. And you can sort your patients by clicking the title of the column. So if you would just click discharge transfer date in this particular page, your patients would sort according to the discharge date, and that would mirror what your EHR is showing you, and it would make it a little easier. That's just a tip. Definitely not important if you don't want to do it, but it's just a way it might make your abstraction process a little easier. Now let's talk numbers of patients. You will have approximately 12 patients per measure that are randomly selected from all of your discharged patients for that particular month that will pre-populate on this page. Now that is because tobacco is noticed on every single patient. You will have approximately 36 patients. Now, the reason I'm saying approximately is because it will depend on how many measures each patient actually qualifies for. The random selection will be pre-populated. That random selection you will need to abstract that number of patients in order to have a valid report. Now, if you discharged 1,000 patients that month, as soon as you finish the required number, which is on the screen initially, and once you have clicked that final patient is closed, the system will automatically pre-populate all of your patients that were discharged that month, and you can continue abstracting if you wish. It is not required. The more data you input into the registry, the stronger your report will be, but it is not required in order to have a valid report. Now let's take it the other direction. Now, let's say you have a smaller agency and you discharge 3 to 4 patients a month. The question has come to us, should you participate? Absolutely yes, because even though on a month-to-month basis your reports may not be strong enough to support gearing or directing your quality improvement efforts, but your quarterly reports where all of your patient information is summarized into a quarterly report, which we'll be producing for you, that should be strong enough to guide your practice. So no matter what size your agency is, whether it's large or small, we definitely support and suggest that you participate in the registry. Now, so let's summarize here on this page, because this is an important fact that you understand before you get into this. How many patients will you be required to abstract? At any point in time, you can close the registry and you're done. But in order to have a valid report, you will need to abstract the volume of patients which is produced, which will be around, if you select all of the measures, it'll be around 36. If you select one measure, it'll be 12. Either abstract the total number of patients pre-populated for the measures you've selected, or the total number that you had discharged that month, whichever number is smaller, and you will receive a valid report. As you move through all of this and you have additional questions or something's not clear to you, please make sure you contact us, because we want to help you with any of the clarity so that you'll understand what this is about. All right, so you have sorted your columns if you chose to by clicking on discharge transfer or whatever column title you wanted. The next thing to do is to get into each patient's record, click the edit button on the left-hand side, and it will take you into your patient's registry. Now you can see I've blocked out a lot of the information, but when you open your own patient's information, you will notice the start of care date, discharge date, patient's ID, date of birth, gender, payment source for that episode of care, diagnosis code, as well as race and ethnicity will all be pre-populated from your OASIS information that you've transmitted to CMS. Now let's say that you have accidentally transmitted incorrect information to CMS. Let's say that your patient was born in 1924 instead of 1974 that is actually showing in the registry. That's no problem. At the bottom of the registry, I'll show you here as we progress through, there'll be a free text box that you can type as a note, that, a little free text saying, patient was actually born in 1924. This information is very important because it will impact the results of your data report that you'll be producing from this registry. If the data is not accurate, you're not going to have accurate information to guide your practice. But here's the kicker. This information, no matter what you do with it, it stops here, meaning it does not go to CMS. So any corrections that you notify us about or any corrections you make, in a minute I'll show you a place where you could change something, that's fine, but it does not go to CMS. Therefore, any incorrect or invalid information that you notice in the registry, you'll need to notify CMS during your normal means of communicating with CMS about inaccurate information that was previously transmitted to them. Okay, I just want to make sure we're clear on that because we don't want you to think that you're making your corrections with CMS when you're actually making it in the registry itself. All right, so as you're going through here and you're making sure you have the right patient, that's the purpose of this information, you'll notice that the race and ethnicity question is actually open for alterations. Again, it does not go to CMS, but there was notice that was requested by CMS that this particular question be open. So for the purpose of discussion, this particular patient was noted per the OASIS to be of white race. Now, if you're going through the chart and you're realizing that that is inaccurate information, you can come back to this question and check all that applied to make it an accurate piece of information. Race and ethnicity is a very important aspect of looking at disparities in care, which we're hoping that this report will help you identify if there are any disparities in care in your patient population. All right, we'll move on down the registry. Normally, you would just scroll down the screen. We'll just click to a new page here, though. First question every single patient will have is what we call the dual eligible question. Was the patient eligible for both Medicare and Medicaid, and was it noted in the record? It's a yes or no drop-down question. Now, the reason for this is because evidence does support certain interventions are better for assisting the patients who are eligible for both Medicare and Medicaid. The dual eligible population does respond differently and better to certain interventions. It's important for the clinicians to know if the patient has dual eligibility. It's also going to be helpful in looking at these reports so that you can see, is there a disparity in care in your patient population? Now, many agencies are already identifying this beyond what is the primary payment source for the episode of care. But if you're not already doing this on intake, we strongly suggest that you do begin flagging your charts as to what patients are eligible for both Medicare and Medicaid, not only for intervention purposes or cardiovascular purposes, but also it's home health. We know there's many times that our patients have to be discharged well before they are what we consider ready for discharge, and that's because they no longer meet the homebound eligibility requirement. If that's the case, it will be very helpful in that kind of emergency discharge planning when you weren't expecting to have to discharge the patient but suddenly found that they were no longer homebound. It will be helpful to be able to identify, did this patient have another payment source to help with maybe custodial care that they're still requiring, or maybe they have some immediate DME requirements, or maybe your state's Medicaid requirements for homebound status are not as stringent as Medicare's homebound status, and maybe that's another option in order to provide care for this patient in the home. Either way, identifying your patients who are eligible for both Medicare and Medicaid as soon as possible during their episode of care, which in most cases is at the initial either start of care or the intake level of the patient, will be helpful on multiple different levels. All right, so this question is Medicare and Medicaid, were they eligible, yes or no? And that's every single patient. Now, if you selected aspirin as an area that you wish to focus, the question, and yes, that is the singular question you will be asked, is did the patient take aspirin or other antithrombotic during this episode of care? Drop-down menu on the right-hand side is yes, no, or contraindicated. Anytime there's a contraindication as an option, throughout the registry, that indicates that it needs to be noted in the record during that episode of care that the patient was contraindicated for this particular issue, in this case, aspirin or antithrombotic. It can be noted by the clinician, or it can be noted by the physician during the physician's orders, or maybe the 485, but wherever it is indicated is fine. What is not okay is for the abstractor themselves to be making this decision. The decision on the clinical aspect of the patient needs to be noted in the record during that episode of care. Another question we get is, what patients does this show up on? Aspirin as appropriate will illuminate for patients who have an ICD-9 code, a medical diagnosis of ischemic vascular disease. And ischemic vascular disease is an overarching term covering patients that have many different vascular issues. It's arterial vascularization, whether that's they have a history of an MI, they have a history of angina, they have a medical diagnosis of a CVA, TIA, maybe there is Raynaud's disease. It's pretty much most medical diagnoses that incorporate the prevention of oxygenated blood from getting to the tissue. And so whatever type of diagnosis, most of those will be covered. So on the ICD-9s, as your patients have, and it is primarily MIs and CVAs, that as your patients are being admitted with any of these diagnoses, then a knee-jerk reaction should be, should they be on aspirin or an antithrombotic? And this is not where a clinician prescribes these drugs or these medications, but it's to ensure that the patient is following the physician's plan of care. So the clinician discussing it with the physician to ensure that the patient is following their plan of care this is where it will take place. We all know as patients move from one care setting to the other, aspirin is one of those drugs that gets dropped very easily, and it's not restarted simply because of a mistake. Someone missed it. And it happens all the time, or maybe the patient took themselves off of it because it was over the counter and they didn't feel it was important enough. That's not what the evidence shows. The evidence supports aspirin usage will prevent MIs and strokes. So we want to ensure that the patient is following the physician's plan of care. Another question we receive is what antithrombotics are included. The only 4 medications that are acceptable to mark yes to this question are listed in the question: aspirin and the 3 antithrombotics listed here. At this time, no other antithrombotics or anticoagulants are included in this question. But again, if the patient is not to be on any of these because they are on an anticoagulant, if that's what the physician states, that's totally appropriate, as long as it is noted in the record. All right, so this is one question, and it's all you have if you selected aspirin. Now let's say that you selected blood pressure. Blood pressure control has 2 questions, and I think if you participated in the pilot, you will notice these are much simpler than before. So the first question is, what was the patient's last recorded systolic, diastolic, and the date it was recorded? You'll notice on the right-hand side there's a little drop-down calendar, and that will help you to just select the date. The second question you'll receive is, was there a better blood pressure control plan to obtain a better blood pressure in the record? Again, it's a yes or no. Now, that's a really broad question, so for the purpose of that question, we listed a few ideas here, such as dietary changes or restrictions. Did the patient receive low sodium instructions? Or did they receive instructions on how to increase their exercise considering their potentially limiting mobility issues? Or maybe there was a weight loss plan developed. Maybe it was hypertension medication education, or maybe the patient received an assessment regarding hypertension medication adherence. I should be saying antihypertensive medication adherence, my apologies. Or maybe the patient's pain was causing their blood pressure to be elevated and they received better pain management. The way to answer yes on this question is that it really it must be noted in the record that this was hypertensive related. For instance, if there was documentation by the clinician that med reconciliation completed, that's a no. Maybe they said med teaching completed, that would be a no. It needs to be specific specific that it was antihypertensive medications that were taught. It needs to be specific that the pain management, better pain management control to better control the patient's blood pressure or to lower the patient's blood pressure. I'm not trying to put words in your clinician's mouth, but trying to get the point across that this is related to hypertension control. And so it needs to be documented as such. If a patient received low sodium diet teaching, that's great, but there's so many different disease processes, there's no way to know as an abstractor if this was because of hypertension, was it because of heart failure, what disease process was it related to. So anything that is related to hypertension, it needs to be noted in the clinician's record or the clinician's charting or documentation. Now, to muddy this up one step further, there is, as we have different clinicians in the home and in home health, there are different scopes of practice. If your patient was a therapy-only case, meaning they only had physical therapy in the patient's home during this episode of care, simply calling the physician and notifying the physician of an elevated blood pressure would be a yes. But if the patient was seen by a skilled nurse at any point in time during this entire episode of care, simply calling the physician is not adequate. A registered nurse's scope of practice is much broader when it comes to working with a patient with hypertension than a physical therapist. So as a registered nurse, contacting the physician, even if the physician didn't want to do anything about the blood pressure, that is perfectly adequate for that physician to say so. But the registered nurse's scope of practice does indicate that an additional follow-up plan, such as maybe checking the blood pressure later, maybe it's working with the patient on self-monitoring, maybe it is helping the patient understand when to notify the nurse or when to notify the physician. Just multiple different interventions would apply here. But it goes beyond simply notifying the physician because independent nursing practice does allow for assessing for hidden sources of sodium or assessing for hidden causes of the blood pressure elevation. As you work through this and you continue on down the road, you'll have different situations with questions. Make sure to send them in to us so that we can address them for everyone in the country to be able to understand what is considered a yes and what is considered a no for these questions. All right, so blood pressure. The last systolic, diastolic, and the date, and was a plan included, yes or no? And that's it for blood pressure. Now, if you select a cholesterol, you'll be asked, first of all, was the patient screened within the past 12 months prior to discharge, yes or no? If you select yes, you'll be asked, how was the patient screened? What particular test? If you answered LDL was one of the options, then you will be asked the final question, which is, what was the LDL value and the date it was obtained? Again, there's a drop-down calendar for the LDL-C date. And that's it for cholesterol. Finally, if you chose tobacco, and tobacco will be for every patient that is discharged from your agency, the question is, during this episode of care, was the patient screened for tobacco use by the home health agency? Yes, no, or not applicable. Again, if not applicable is decided, it needs to be noted in the clinician or the physician's notes during that episode of care. If you mark yes, the patient was screened, then you'll be asked, was the patient a user? If you mark yes, your final question is, did the patient receive any type of tobacco cessation counseling or pharmacotherapy during this episode of care? Keep in mind, when we're talking about tobacco cessation counseling, we're only talking about a brief counseling session of 3 minutes or less. If you haven't looked over the past 6 to 9 months or 12 months of what interventions are available and what tools are available for clinicians in the home to assist the patient in understanding what the tobacco use does to their health, we really suggest you have a look at the Cardiovascular Best Practice Intervention Package, or BPIP, Part 2, as it is full of resources for the clinicians to utilize in the home talking about smoking cessation. There are paper as well as electronic. There are videos as well as PowerPoint slideshows. There's just everything for the clinicians to have access to. You know, in the home, we have a really strong advantage in home health over other healthcare providers because the patient, when they're at the physician's office and they have that brief period of time to interact with the physician, they may be having white coat syndrome, they may be having all kinds of different things. In such a short period of time, they're not really as receptive to information on healthcare practices. Same thing with the hospital. You know, the patients are probably a little on the sleep-deprived side. They're also probably having some discomfort and they're anxious to get out of there. And so that's, again, not the best place in the world for a patient to receive information about general healthcare. In the home, where the patient is comfortable and they've gotten to know the clinician and the clinician knows the patient, the family, the dog, the children, the brothers. Everybody knows everybody. It's the beauty of our setting. This is where the patient will probably be the most receptive to hearing the information of how smoking and tobacco use actually hinders their wound healing, hinders their lung function, hinders their cardiac output, and helps how we can help them decrease their smoking and their tobacco use. So this is a situation where we want to take advantage of being in the home and being familiar with the family and having multiple opportunities to work with the patient. And like I said, the brief counseling, it's just 3 minutes or less. That's all that's required. So if the patient was receiving pharmacotherapy for tobacco cessation, or if they received any brief counseling, 3 minutes or less, that would be a yes for this question. And that's it. At the bottom of the tool itself, you will see the free text space. This is where I mentioned you can write us a note letting us know that maybe you accidentally marked the patient as male and they're actually a female. This will impact your report. So let us know so that we can alter that before the report is published. Do remember, you'll need to correct it with CMS because your OASIS was transmitted incorrectly during the normal method that you always take. Now, once you've completed with this patient, you'll want to go ahead and click Save, and it will take you back to the main screen. And let's say you want to get into the registry and just have a look around. Before you even access the patient's chart, you want to really see if this is as easy and simple as we're talking about and about these drop-down menus. Feel free. This registry is yours. We just ask that once you have gone in and what I call played with the registry, that's perfectly fine. You're not going to break it. Don't take that as a challenge, but you won't break it. Instead of clicking Save when you're ready to leave this patient's record from just looking around, just click Close without saving, and it will be as though you were never in there at all. Whichever button you choose, it doesn't matter because you will end up back onto the main page. And here you will just click the next patient down, click the word Edit, and you'll start the process over. Once you've completed all of the patients that are pre-populated for your valid report, you'll want to click Close out the month. By closing out the month, this indicates to the system that your agency is ready to have the report generated with the next batch of reports. Now, when you click Close out the month, you will get a pop-up that is it's scary. It has a lot of red ink on it, a lot of exclamation points. It's asking, are you really sure you want to close out the month? The reason for that is that once you close out the month, we cannot reopen it. So you get a second opportunity to back out of closing out the month if you're not really ready to do that. But once you have completed your patients, click Close out the month, and the next time the reports are posted, you'll have your HHCDR report. Now, a few dates to remember. The 15th of every month, the HHCDR will open and pre-populate with the patient information of your selected patient. Let's use this month. November 15th, the registry will open. It's going to have your patient information in it. On the 14th of December, the 14th of the following month, all data that is closed, as you've closed out your month, that data will be pulled to generate your report. So it opens on November 15th. Close your reports if you can by the 14th of December, and then by around the 23rd of December, when you're receiving all of your other HHQI data reports, such as your ACH, oral med, your flu and pneumococcal, your cardiac risk report, you'll also receive the HHCDR report at the same time in the same location. Now let's say you started on November 15th. You were all gung-ho. You were right there going at it, and something came up. You got pulled away from the registry. Then Thanksgiving came and holidays came, and you forgot about it until the last couple days of December. You'd already missed that 14th of December to close it out. What do? Your data is not going anywhere. The data you put into here is not going to expire. It's not going to erase, and it's also not going to be used to create a report until you click Close Out the Month. So the data you have inputted into the registry will sit there until you proceed further, or it will just sit there forever. So if you come back around the, 29th of December and you remember, I was supposed to finish that up, no problem. Open it back up, finish out the patients that you hadn't gotten to yet in the registry in November when you were trying to do this, close out the month, same as always, and proceed on. Then when your reports are produced the following month, you'll have the November report as you would have at any other point. Your data does not merge with other months. It doesn't matter when you do this. If you open the registry in July and you're abstracting your September 2014 patients, it's still going to be your September discharges when you look at your report. It doesn't matter when you abstract. It will still be for that particular month's discharged patient. So what I'm trying to say here is do the best you can, but if you forget about it, because this is a new process, it's going to take some getting used to. And when that happens, just come back to it. The patient's still going to be there. Now, a couple different resources that I wanted to share with you at this time that may help you. Absolutely don't feel obligated, but if they will help, I wanted to make sure you were aware of them. The first is called the HHCDR Chart Abstraction Tool. Now, this is a PDF, and it is in electronic format currently. You can print it off. You can enter your information electronically. You can do with it as you will. It's simply a chart abstraction tool. And the reason for this, because we had some agencies who were asking for something that could be utilized by the case managers before the patient was discharged from the agency. Like I said, the patient will be discharged and they will not show up in the registry for about 6 weeks more, until 6 weeks later. So what some agencies have done, and they've reported a lot of success with this, is they'll print off a copy of this, or they've embedded into the EHR, and the discharging clinician can complete this because you know they're going to know this patient a lot better than probably an abstractor would, and especially because they're doing it during real time of taking care of the patient versus 6 weeks later. And once the clinician does it, especially if it's paper, then just put it in a folder wherever you keep your secured chart, patient information in whatever room that is. Just keep the folder in there, mark it which month the patient was discharged on, so that when the patient pre-populates in the registry, you can just pull that folder out, enter the information off of these sheets, and you don't have to actually dig through the chart unless you want to. Again, absolutely no obligation to do this. It's just if you are interested in doing this, it is available. And it's available under the right-hand side on the data resource page under the step-by-step manuals and webinars. You'll find this chart abstraction tool. It has all of the questions. Again, it's right there for your use. Feel free to use it or not. It's completely up to you as to what works best for you. Now you'll notice in the bottom of that, underneath the step-by-step manuals and webinars, there are the FAQs as well. If you can't find your question or your answer either in any of these webinars or the FAQs, you can always contact us up by pushing the Contact Us button on the left-hand side. Now the second and final resource I wanted to share with you is called the Cardio LAN. It's a Learning Action Network. It is a group of folks who are not just home health agencies, but they're across multi-provider settings that are interested in improving cardiovascular health. Granted, most of the participants in our Cardio LAN will be home health agencies, but everyone is welcome to participate. We'll hold monthly calls, whether that will be webinars or teleconferences. It will change from month to month, but I wanted to show you how to sign up for it so that you'll be able to receive information of when the calls are occurring or when the webinars are occurring and the login information. So if you return to the main HHQI website, which is www.homehealthquality.org, And if you'll hover your cursor over cardiovascular health and click CardioLand, first link in the tan, and that will take you to this page. Now, you may already be signed up for this, but in case you're not, you can click the big blue button on the right-hand side, and it will just link your account so that you'll receive a once-a-month email giving you the call-in information or the webinar information of how to sign in and access the monthly calls. Those will be on the third Thursday of every month at 2 o'clock Eastern. They will be recorded and archived, and you'll be able to listen or watch if there's a webinar included. We'll include information in there about the updates of HHQI and what is coming forward, so you will be one of the first to know what's going on in HHQI. We'll also cover information about the registry, but we'll also have speakers from around the country. Some of the speakers may be home health agencies with success stories. Some of the speakers may be national presenters who have information on maybe tobacco cessation or maybe different blood pressure elements. The topics will vary, but it will be cardiovascular focused. So that it's really a melting pot where everyone can kind of come together and talk about cardiovascular in the home. And of course, there will always be enough time for discussion and questions about anything cardiovascular related or home health related that we can assist in. The other reason to join the CardioLand is that you will get national recognition by this interactive map. This is a public site, and your agency's information, not your personal information, but your agency information will be on a list that when a participant or when anybody comes into this site and clicks any state on this interactive map, they will get a list of the agencies that are participating and interested in the improvement of cardiovascular care. You are in no way obligating yourself to anything at any point during HHQI. Remember, this is a totally voluntary movement and initiative. The CardioLand is just yet one more tool that we want to provide home health agencies to support your actions. Join, you'll get the information. We'll share with you where the links are so you can listen to the recording, and let us know what we can do to help. So with this, we'll conclude this webinar. Remember, you can locate us. We're at www.homehealthquality.org, and you can always email us at hhqi@wbmi.org. And with this, we'll conclude this webinar. Thank you.